for this presentation. So at the outset, what I would like to tell you is that this presentation is not the know all about primary liver cancers. This is just a starting point as to what you should see when you see a patient who has primary liver cancers. You should have a broad idea as to how to approach these patients, how to assess these patients. Uh, uh, I'm sure you'll have a lot more to ask after the presentation, so I'll be happy to take your questions beyond that. So now let's talk. So let's first differentiate primary liver cancers from other liver cancers. See, the most common type of liver cancers are actually secondaries, meaning liver metastases from other organs. So colorectal liver metastases, neuroendocrine tumor liver metastases. See a breast metastasizing to the liver. But today we are not talking about those cancers. What we are talking about is the cancers which actually originate from the liver. So you've got two cells in the liver, major cells, which can, give rise to cancers. One are the hepatocytes, and one are the bile duct cells, which are known as the cholangiocytes. Now, why are we talking about these? One, because these are treatable tumors. I mean, there's a fair chance that if caught in time and if treated appropriately, patients can have a real shot at long-term survival. Now, more than 800,000 deaths happen annually because of primary liver cancers. Majority of these are hepatocellular cancers, and now, as the name suggests, hepatocellular, meaning they originate from the hepatocytes. Now, they have a high burden of disease in East Asia and North Africa. The other type of liver cancers, primary liver cancers, are cholangiocarcinomas. Now, as you see, cholangio means bile duct. So cells of the bile duct can also develop cancers. They are differentiated based on where they originate from. Now, we are not going to talk about the extrahepatic bile duct cancers. What we are going to primarily shed some light on would be the intrahepatic. As you can see, they are within the liver, meaning they originate from smaller bile duct cells, or perihilar. Perihilar meaning near the hilum. So this is the hilum where the right and the left hepatic duct join. So if a cholangiocarcinoma originates here, it is known as perihilar cholangiocarcinoma, or a Klatskin tumor, as it was initially called. So what are again? So hepatocellular carcinomas. These are the most common. About 80-85% are hepatocellular carcinomas. Uh, Now, hepatocellular carcinomas and cholangiocarcinomas originate in different patient sets. Majority of the hepatocellular carcinomas would originate in patients who have underlying cirrhosis. However, in perihilar and to some extent intrahepatic cholangiocarcinoma, uh, even though cirrhosis is a risk factor, but majority would develop a hepatocellular carcinoma. How do you differentiate, perihilar and intrahepatic? As I said, so first is the location. So if it is originating near the bile duct confluence, it is called as hilar cholangiocarcinoma. And if it is from within the liver parenchyma, it is intrahepatic. Appearance, obviously, it will either cause narrowing of the bile duct in hilar cholangiocarcinomas, and because those are the major highways through which bile comes down, they will cause biliary obstruction, and jaundice thus in these cases would be early and prominent. Compare this to a intrahepatic cholangiocarcinoma, as it is arising within the liver. So these may not present early. Majority of them will present as mass forming lesions, as a liver mass, and they would usually present late unless you have evaluated the patient for some other thing and incidentally have found these tumors. As I said, for hepatocellular carcinomas, viral hepatitis, chronic viral hepatitis, cirrhosis, elderly age, family history are the risk factors. And additional risk factor for cholangiocarcinomas are choledochal cysts. What are the screening strategies for hepatocellular carcinomas? Usually, what you do is, if you know that there is a patient who has cirrhosis, you would ask them to stay under follow up, and every 6 months, you would ask them to undergo an ultrasound and an alpha-fetoprotein, which is the tumor marker for detection of hepatocellular carcinomas, to get these tests done. Now, this is a fair screening strategy and has been known to improve survival in these patients. Now, as we discussed, AFP is the primary tumor marker. There is another tumor marker which is called as PIVCA2. Both of these would be elevated in hepatocellular carcinomas. CA19-9 is the tumor marker which would usually be associated with biliary tumors or biliary obstructions. However, sometimes what we've seen is that even in patients with hepatocellular carcinomas who have underlying advanced liver disease, these CA19-9 can be elevated. So yes, they are sensitive, but they may not be very specific. Now, imaging, how do you do? As we discussed, ultrasound is the screening modality. CT is the, you know, primary radiological investigation that we would usually order in HCCs. One, because we as surgeons are more adept at seeing CT scans and evaluating that. Probably for a fair majority of us, CT scan also gives a better anatomical evaluation. Vascular invasion and all probably is better seen on CT, or at least is seen in our eyes. MRI, even though, is better to pick up even smaller lesions, because another issue is that the acquisition time is higher. Patient may, because these are sick patients, they may not be able to hold their breaths. So sometimes the quality of the images may not be as good, but certainly head to head, MRI picks up more lesions. They pick lesions earlier in HCCs. As we discussed, MRI does have distinct advantages over CT scan for evaluation of these lesions. Now, this was the earliest BCLC Barcelona staging classifications for hepatocellular carcinomas. What we need to basically know is that early tumors, small tumors, if the either if they arise in a liver which has no background cirrhosis, or the portal pressures are not high, basically child A status, then resection can be offered. However, if the pressures or bilirubin is elevated, which is a marker that the liver functions are not up to the mark, meaning they are reduced, these are the patients which should be offered liver transplantation. Now, liver transplantation in HCC is one of the best treatment options. One, because you are taking care of the underlying chronic liver disease. So once you remove the diseased liver, uh, if the patient has other symptoms of liver failure, those would also be taken care of. Second, you are removing the pre-malignant stage. So cirrhosis is considered to be a pre-malignant stage. You have a tumor today, either you resect it, or you microwave it, or you do a TACE. Even if you achieve complete ablation, there is a fair chance over the next 5 years, 70% of these individuals will develop another tumor, because it's a pre-malignant condition. So the second time when it comes, either you have the option of doing a salvage transplant, but sometimes these patients may not be picked up in time. There may be vascular invasion which may not allow transplant to be an option. So upfront transplant in these patients is an excellent choice. Tumors which are multifocal within criteria can be offered transplant. We will be talking about what to do in these advanced stages. Even though BCLC had come earlier, there is a new staging. As you can see, this is a much more you know uh, busy slide. we will not be talking about it upfront. We will be talking about it in the upcoming slides. So, what are the treatment principles? You have to treat based on the stage. The idea is to try and preserve liver function. So, if you're doing a resection, if in a patient who has underlying cirrhosis, you will not be able to remove a major part of the liver. So, if it's a small tumor which you can resect, or if a tumor is small but it is deep seated, where if you cut, the majority of liver will come out. So you can either use a microwave ablation or a radio frequency ablation or a TACE procedure. MDT has to be done. All tumors you need to try and do multidisciplinary team meetings, because you have to formulate a plan for the patient in the long term, not just for that one particular lesion. So as we discussed, resection is an option if liver functions are preserved, or if it is a superficial peripherally placed tumor. If either liver functions are deranged, patient has signs of liver failure, and the tumor is within criteria, then liver transplant is an option. Ablation becomes an option either as a bridge to transplant, or as a primary treatment where resection and ablation can be, so for early small tumors they can be may have equal results. So as we discussed, for hepatectomy in HCCs, early cirrhotics, meaning child A, where liver functions are preserved and tumors are small and resectable, that can be done. Ablation like radio frequency or microwave are primarily good for small tumors, again because you're not doing a laparotomy or a laparoscopic surgery. You These are minimally invasive. TACE can be done for slightly larger tumors and for tumor control, as I said, as a bridge to transplant. Radiotherapy like SBRT or even transarterial radioembolization. These are options when in a cirrhotic the main portal vein is involved, because you can't do surgery with a tumor portal vein invasion, especially in the main portal vein invasion. However, you can do TARE or an SBRT along with TACE for the primary tumor, where the TACE takes care of the primary lesion and the invasion in the portal vein can be taken care of by the SBRT. Beyond this, if the tumor does not spread outside, transplant can be offered. Systemic therapies include, sorafenib, lenvatinib, and nowadays even immunotherapies, including atezolizumab and bevacizumab, have been used. These can be used again. There is new data coming in where you can even use this as, downstaging therapies for HCCs. Now, now we were talking about criteria for transplant. So the earliest criteria that had come, was Milan's criteria, where if there was a single tumor less than 5 centimeter or up to three tumors all smaller than 3 centimeters, if you offered transplant as a treatment option, these patients had very high survival. These criteria have been extended. You have the UCSF criteria which came in next, where a single tumor less than 6.5 centimeters, or three tumors, all of them less than 4.5, and a total tumor diameter less than 8 centimeters, again had comparable survival to Milan. So a lot of patients who were beyond Milan could be still transplanted and have very good criteria. Beyond this, nowadays there are newer criterias which are coming in from different hospitals and countries, where even larger tumor sizes or higher tumor burdens can be offered transplant either as a primary treatment option or as after some neoadjuvant therapies. So as we are now talking about neoadjuvant therapies, so what do we do in a patient who has an HCC but does not fall into the UCSF or the Milan's criteria, or if the portal venous invasion is present? So what you can do is you can give either these immunotherapies, or you can do percutaneous ablations, even TACE or TARE for portal vein invasion. If you have stable disease which falls within criteria after you have achieved downstaging, you can offer liver transplantation. Obviously, the recurrence rates for these tumors would be slightly higher compared to patients who were originally within criteria. However, the only other option for these patients is best supportive care, which obviously will have a very high mortality in the long term. Now coming to intrahepatic and hilar cholangiocarcinomas, as we discussed, intrahepatic cholangios are peripherally located tumors arising from the bile duct within the liver. About 10 to 15% of primary liver cancers. Uh, Compared to the other primary liver cancers, they may have a poorer prognosis, primarily because these are picked up late, because a hilar cholangiocarcinoma would arise somewhere around the hilum and cause jaundice early, so they will be picked up earlier. Now these tumors would be peripherally placed, they will continue to grow, may spread through the lymph nodes, and be picked up later, and thus may have a slightly poorer prognosis. PSC, hepatolithiasis, colorectal cyst, liver flukes, even cirrhosis, as we discussed, does increase the risk of intrahepatic cholangiocarcinoma. Late presentation primarily as liver mass, or these B symptoms: pain, weight loss, asthenia. These may be the symptoms. These can be mass forming lesions. They may have peripheral enhancement and progressive delayed enhancement. Sometimes what we see is, if these are peripherally placed tumors, there is capsular retraction on CT scans, where the liver margin will indent from these tumors. What are the treatment options? Surgery is the only option. So you have to aim for resecting these tumors. An R0 resection, meaning negative histological margins, need to be achieved, and lymphadenectomy, because these hilar and intrahepatic cholangiocarcinomas spread through the lymph nodes. These tumors have the peri hepatic lymph nodes need to be removed. Staging, I mean, yes, we have the AJCC classification, but what we need to understand is that the idea is that you need to be able to resect the whole tumor. Only then will patients have a chance at long-term survival. Now, for hilar cholangiocarcinomas, we use the Bismuth-Colruyt classification. So you see, type 1 is a tumor which arises near the hilum. However, you see, compared to type 2, the right and the left hepatic duct junction is joined. So if you have this kind of a tumor, you may get away with removing only the bile duct and not need to resect the liver. However, if you get a type 2 tumor, you may still be able to resect this and be able to rejoin the bile ducts doing a hepatico or a cholangiojejunostomy. However, the problem is that, because these tumors do spread along the mucosa, you may have to do some kind of parenchymal resection around the tumor. In type 3A, because this extends into the liver, uh, you have to do a major liver resection, what is called as a right trisectionectomy. See, this tumor involves the main common hepatic duct, it involves the hilum, it involves the secondary radicals of the right side of the duct and some part of the left duct. So what you have to do is, you have to come like this and resect it like this. Caudate always comes off, caudate lobe always comes off when you have a hilar cholangiocarcinoma, because majority of the times the bile duct of the caudate lobe is involved. So you end up doing what is called as a right trisectionectomy. Compare this to a type 3B, where the second order radicals of the left side of the duct are involved. Now these tumors will require a left or a left extended hepatectomy. You have to remove all of this liver parenchyma simply to get negative margins. That is why the surgical options are more complicated in a hilar cholangiocarcinoma. In a type 4, because both sides are involved, upfront surgery may not be possible. Now, sometimes what we see is if we are trying to do a right trisectionectomy, the left lateral section may not be large enough. So you may end up doing what is called as a portal vein embolization of the right side, where what you do is you block the portal vein pedicle of the right side of the liver. Now, the preferential flow of the portal vein goes towards the left side. Right side does not receive its portal flow, so the right side shrinks in size and the left side increases in size. And thus, you may be able to now resect this and have a good future liver remnant for these tumors. It may not be as commonly required in a type 3b tumor because the posterior side of the liver, that is the right posterior section, usually is large enough to take care of all the liver functions. These patients usually will present with jaundice. So if they have upfront cholangitis, or they are significantly asthenic, or if we have to do a portal vein embolization, then they will also need what is called as a preoperative biliary drainage, where you drain the side of the liver which is going to be preserved, so that the jaundice comes down and the predicted future liver remnant also gets a chance to get better, because you have allowed it to drain, the biliary drainage to happen. The problem with hilar cholangiocarcinoma is that, if you see, the major blood vessels run very close to the biliary confluence and hilum. So the right hepatic artery runs pretty close. You've got the portal vein behind, which is extremely close. So many times what will happen is that even though the tumor may be very small, but it will involve these major vessels and may require resection reconstruction of these major vessels. So uh, coming to adjuvant treatment, if the patient is stable enough, then capecitabine can be used in the adjuvant setting, which is known to improve survival. Gemcitabine and capecitabine have been used in the neoadjuvant setting for downstaging for these patients. Uh, Appropriate selection of these surgical candidates is extremely important. The idea is to achieve R0 resection in intrahepatic cholangiocarcinoma. However, what we have seen is for hilar cholangiocarcinoma, even if you get an R1 resection, because majority of hilar cholangiocarcinoma patients may not die because of liver failure. What they will die from is cholangitis, severe, cholangitis sepsis, which will lead to their death. So if you're able to remove these tumors, have even if you get an R1 resection, R1 meaning you have a histologically positive margin. Now, because you've done a biliary drainage, they'll have a lot of survival, which will be much better than patients who've not been offered surgery at all. In advanced intrahepatic cholangiocarcinomas, as we've discussed, gemcitabine, cisplatin forms the first line treatment. Immunotherapy can be offered. Targeted therapies have been, used in some studies. So coming back to what are the key differences between cholangiocarcinomas and hepatocellular carcinomas, you've got bile duct origin in cholangiocarcinomas. The hepatocytes are the site of tumor development in in cholangiocarcinomas, you've got bile duct origin. In HCCs, that is hepatocellular carcinomas, you've got the tumor originating from the hepatocytes. CA19-9 is the primary tumor marker for cholangiocarcinomas. Alpha-fetoprotein and PIVKA2 are the tumor markers for HCCs. On the CT, what you will see is progressive delayed enhancement in intrahepatic cholangios. In HCCs, there's a classical finding of arterial enhancement and delayed venous washout. So HCCs, especially early tumors, are primarily supplied by hepatic arterial branches. That is why they will have a higher enhancement compared to the background liver in on radiology. In the later phases, that is the portal venous, hepatic venous, or the delayed phase, because the hepatic artery would have washed out the contrast, and they do not have portal venous supply. So they will show a lower enhancement compared to the background liver. So you will have a tumor which will be darker compared to the background liver. That is called as a washout. So that's the different, and obviously the treatment pathways are different. So thank you. So this is regarding, just a overview of uh, hilar intrahepatic and hepatocellular carcinomas. Uh, Again, this is not a complete detailed presentation. The idea was not to give you everything. The idea was for you to know which are the patient profiles which would probably have these kind of tumors, and also what to do when you get a patient who has these tumors. Any questions, any doubts, I'll be happy to answer.
Dr. Ashish, you during the talk you talked about the recurrence rates in even after surgery. If you can expand a little bit on that for our
Yeah.
understanding what Dr. talked.
So, so hepatocellular carcinomas, as we just discussed, these primarily develop on a background cirrhotic liver. Now, cirrhotic liver is like a field, a fertile field. You have one tumor developing from one place. You may remove that, but you'll have these cells which have a higher tendency to continue to turn into or mutate into cancer cells. So because you've got a background liver which is still cirrhotic, and there is a chance of these tumors developing again. So if you remove this primary HCC, which may be resectable, or you do a microwave or an RFA, these patients still have a higher risk of developing tumors in the future. So transplant, that is why upfront transplant may be uh, arguably a better option in these patients, where because you're removing the whole diseased liver and giving a new liver which does not have this risk. The risk of recurrence may be lower compared to resection or microwave alone.
We have a question from Dr. Siabilo, and he raises a very important issue that the majority of their HCC patients they present late with very large lesions, solitary or multiple, as large as up to 10 centimeter. So, what would be the best criteria for them to use when considering resection? So, I mean, liver transplant capabilities are not present in majority of the countries, so they have to, you know, operate under those constraints as well. So,
See, if the so we have sometimes patients from vertical transmission of hepatitis B or C. Sometimes what will happen is the background liver might be absolutely normal, and these are carriers of hepatitis B. So they may have large tumors. So if you have a background liver which is completely normal, so extended resections can be done. You can use portal vein embolization of the involved side to increase the size of the future liver remnant on the size which is site which is going to remain, and then resect these tumors. However, if the background is cirrhotic, then all attempt needs to be made to see if there is any extrahepatic disease. So if there's no extrahepatic disease, the next thing that what we would want to see is, is there major portal venous invasion. Now, how do we classify portal vein invasion? You've got VP1, VP2, VP3, VP4. So you've got the main portal vein, then you've got the right and left branches, then you've got right anterior, posterior, and then you've got segmental branches. So if the segmental branch is involved, meaning you've got a small tumor and a segmental tumor portal vein thrombus is present, that is called as VP1. VP2 is when sectoral branch is involved, meaning a right anterior or a right posterior sectoral branch is involved. That is called as a VP2. VP3 would be when the right main or the left main is involved, and VP4 is when the main portal vein is involved. Now, why I'm now coming to this is that if you have a VP1 or a VP2 tumor, even though you have a large primary and a VP1 or a VP2 involvement, these patients can actually be offered, and there is no extra hepatic disease. These patients can be offered liver transplant either upfront or after downstaging. How do you do downstaging? Uh, you can do a TACE for the primary. Now, for large tumors, obviously, sometimes a single session of TACE may not be enough. You might need to do TACE over 1 or 2 or 3 sessions. And if you have a tumor thrombus in the sectoral or the right portal vein or the left portal vein, this tumor thrombus can be treated with SBRT. Sometimes we've even used SBRT for the primary tumor, which is very large, and our intervention radiologist says that TACE may not be a very good idea. Now, the whole aim for these patients is you have to try and get them uh, to stable disease over three months, 12 weeks, where you have no extrahepatic disease. There's maybe a significant reduction in the tumor markers, and there's no progression of the disease within the liver. If you are able to achieve this, then these patients can be offered liver transplant.
Dr. Seblo, does that answer your question? Or
Yes, thank you so much. We do have a lot of patients who have a non-cirrhotic HCCs, mainly hepatitis B. We have these patients who require, you find that a good number of patients are resectable with 2 centimeter lesions. Yes. But we always have challenges in terms of just getting them optimized for surgery.
True. See, again, I mean, we are extremely aggressive when we get a non-cirrhotic liver. Now, for us, these are not as common. I would say, out of 100 HCCs, maybe 95 that we see are in a background of cirrhosis, and only 5 are having a non-cirrhotic liver. However, for these 5 patients, we'll do extended resections. We'll use portal vein embolization. Even ALPS is an option. For that is a staged hepatectomy is an option for these patients. Because you have a liver. So normally what we say is, if the liver is normal, even if you remove almost 80% of the liver, the remaining 20% should grow back and be able to take care of all the functions of the liver. So that is why we are much more aggressive in these patients for resection as a treatment option.
now we have a comment from Dr. Orunana Paul Adugbo.
So
So he's
I'm still just stopping. So there was one question in the chat. How do we make a diagnosis of HCC, and if
Yes.
liver biopsy is common? No. So the most HCCs are tumors which are which have a very characteristic finding on CT and MRI. So biopsies are only done in tumors where there is a diagnostic dilemma. We do not do biopsies often. If you get an arterially enhancing lesion and a venous washout, that's almost diagnostic of an HCC on CT. However, what you need is not a simple contrast enhanced CT scan. What you need to do is a phasic CT scan. You need to do a triple phase CT scan where you take an arterial phase first, then you take a portal venous phase, then you take a hepatic venous phase, and then you take a delayed phase. Sometimes the delayed washout can come after 5, 7, 10 minutes also. Occasionally, if we are not getting our diagnosis based on the CT, we might even need to go ahead and do a contrast enhanced MR in these patients. Diffusion restriction, and similarly arterial enhancement and venous washout, these are typical, which we, I would say, almost 95% of patients that we see of HCC are easily diagnosed on radiology by doing a phasic or a triple phase scan of the liver. only 5% patients where these patients are already either metastatic, or patients are so sick that you can't offer curative treatment options, where biopsy is required, maybe as a closure for these patients, or you are planning at some treatment either in the neoadjuvant setting. Even many times, or I would say not many times, almost all of the times, if we are sure that the disease is HCC, you have a background cirrhosis, you have a tumor where maybe you've got portal venous involvement, and you need to take care of this, because it obviously signifies advanced disease. You need to take care of this upfront. So you do a TACE for the primary lesion, you do a SBRT for the portal vein tumor thrombus, or a tear for the primary lesion and SBRT, and then wait and then do transplants. Only patients which we are saying that are only for palliation, maybe we will be doing biopsies, or if there's a diagnostic dilemma. Otherwise, liver biopsies are very rarely done for HCCs. Now, AFP may not be so. Of the 100 patients that we see, maybe only 40 patients may have elevated AFP, 60 may not have it. We also use PIVCA2, which increases the sensitivity a little more. But even if we've got a lot of patients where AFP and PIVCA2 may be absolutely normal, and we would still be sure of our diagnosis based on the radiology.
Okay, thanks, Dr. Ashish, for answering this in detail. I mean, it really.
So another question that's there is, in cholangiocarcinomas, do we have any particular cutoff at which we would not operate? Absolutely no. So we've had patients with a bilirubin of 30, 35, and here we are talking about hilar cholangiocarcinoma, because intrahepatic would usually not present with jaundice, and by the time intrahepatic involves the hilum, tumors are usually unresectable. In primary perihilar cholangiocarcinomas, uh, now what we see is, initially, maybe 5, 7, 10 years back, we used to do extended resections where we would only end up with the left lateral section or the right posterior sector. Nowadays what we do is, we can sometimes do a left with caudate or a right with caudate resection, and do some extended resection of the bile ducts to preserve more liver parenchyma. So in these kind of patients, if we are not doing a trisectionectomy, we would, unless the patient has cholangitis, we would go ahead, and even without pre-op biliary drainage, we might resect. But if the patient has cholangitis, if we are planning upfront portal vein embolizations for extended resections, because you need to give the best chance of the future liver remnant to expand in size, so you need to drain the future liver remnant. In those patients, we might do a preoperative biliary drainage, either with a PTBD or with an ENBD. Majority of the times in our setup, we are using PTBDs and not ENBDs. ENBD is the nasobiliary drainage. So next question is, between CA19-9 and alpha-fetoprotein, which is more specific? Obviously, so alpha-fetoprotein is the tumor marker which is primarily elevated in hepatocellular carcinoma. CA19-9 primarily comes from the biliary system. As I said, it may be elevated in patients with cirrhosis, but the level of elevation is not very high.
Dr. Ashish, we have missed one question from Dr. Ornana Paul. It was earlier.
I'm sorry, what is that?
So he thanks you for the presentation. So after the surgery, does the patient take any anti-cancer drugs? If yes, what drugs are they placed on? It was before a question of Dr. Francis, where he asked about diagnosis about HCC. So if you scroll up, it was the okay.
In
I'll read.
non-transplant setting for large
No,
tumors
no,
of
no.
still
That is a comment.
after the surgery, does the patient take any anti-cancer drugs? If yes, what drugs are they placed on? So let us first talk about hepatocellular carcinomas. Uh, if we do in a background normal liver, if you're sorry, if we are doing a resection, we would place these patients on lenvatinib majority of the times for prolonged period of time. For patients who have undergone transplant, usually no adjuvant treatment with respect to these drugs are done. What we would do is the standard immunosuppression would be modified. So there is a drug which is called as everolimus, which has been associated with a lower risk of, it's an immunosuppressive drug, which is associated with a lower risk of recurrence in the post-operative setting in HCCs in patients who've undergone liver transplant. So instead of our standard immunosuppression with tacrolimus and mycophenolate, what we would do is we will do tacrolimus plus everolimus. So there's this is what we do in hepatocellular carcinomas. With respect to cholangiocarcinomas, usually if there is lymph nodal invasion, which is generally seen for advanced diseases, if there is a vascular invasion, these patients would be referred to our medical oncologists. Now, whether these patients are fit for adjuvant chemotherapy would be decided by the medical oncologist. Many of these patients may be run down, so they may need some time before they get better, because they'll have preoperative jaundice, cholangitis, recurrent cholangitis. These are asthenic patients. Once they get better, maybe after 6 weeks to 12 weeks, then adjuvant therapy can be offered. Usually this would be cisplatin or gemcitabine based treatment. We are using in cutoff for bilirubin, as you know. So in the one hepatectomy I observed, the patient developed deranged bilirubin and liver enzymes following a Pringle maneuver performed during the operation. It was treated initially conservatively and then stented during ERCP. Is this a common complication of performing the Pringle maneuver? So no, this is not a common complication. Um, Usually, if you are requiring, a stenting in these patients, that means that the bile duct is involved. I mean, either so if you've done a resection, so let us, for example, let us say we've done a right hepatectomy, and we have the confluence which is intact. I'm talking about an intrahepatic cholangiocarcinoma. You've done a right hepatectomy. The confluence is normal. Now you've done a right hepatectomy and you've closed the biliary confluence. If by accident the confluence is narrowed, then the patient may develop jaundice. Or if in a hilar cholangiocarcinoma you've done a hepaticojejunostomy, where for some reason patient has maybe developed a bile leak which has later led to a biliary stricture, then these patients may develop jaundice in the post-operative period, which may need stenting. The only other setting where jaundice, I can think of jaundice developing would be you've given preoperative radiotherapy, and the bile duct itself, the vascularity is in question, and you've done anastomosis again, causing maybe a biliary stricture. Otherwise, with Pringle, you may have liver enzymes elevating, but jaundice secondary to biliary obstruction should not happen.
Dr. Atish, there's another question from Dr. Siablo. In terms of follow-up, once resected, what is the guidance on follow-up for HCC and CCA to prevent recurrence?
Yeah, so for hepatocellular carcinoma, as we just discussed, if you're doing a resection or even a intervention radiological procedure of a microwave or a TS or a radio frequency ablation, because the background liver still has a risk of developing cancers, you need to keep them under follow-up, a strict follow-up. Usually, resected patients may need more, detailed radiology, not just with an ultrasound. We may need to do MRI screening MRIs instead of, because see, you can even use CT scans, but there is a risk of radiation and contrast nephropathy. So MRI comes up more often in the follow-up of these patients, because you also want to pick up smaller lesions earlier, and if they are still resectable, maybe offer resection or offer transplant as a salvage therapy for these patients. Now, with respect to cholangiocarcinomas, uh, in the adjuvant setting, usually you would again use either CT scans or MRIs more often than simply ultrasounds, because ultrasounds may not pick up these lesions early enough. And obviously, tumor markers would be done: alpha-fetoprotein, PIVKA2 for HCCs, and CA19-9 for cholangiocarcinoma.
We have one gastrosurgeon, Dr. Olyanka. He was in India
Hello,
recently.
hi, Dr. Alyanka. Good
He
to
did
be
his
your acquaintance.
he did his fellowship under Dr. Nandi in Gangaram. He was here.
Oh, that's
Very
that's
good.
that's a very good place. I mean, Dr. Nandi. So I have been trained at All India Institute. Dr. Nandi was the surgeon who started the department of GI surgery at All India Institute, which is the premier most institute in the country. So yeah, I mean, Dr. Nandi is an excellent teacher.
Thank you very much. I had an interesting time with Dr. Nandi. That was last year when I came to India. And
Yeah. So my
can assure
friend
you that,
Dr. Aurobindo, I'm sure you would have met him.
of course, I
He's
did.
there.
I
Yeah.
did a lot of cases with him, Aurobindo, then
Yeah,
and some other
we
faculty.
were batchmates when we were doing our GI surgery super specialty
So,
subspecialty at AIMS.
so Dr. Olyanka, Dr. Sandeep and Dr. Ashish are also batchmates from MBBS days.
Oh,
Yeah,
that's
Dr.
great.
Olyanka has met Dr.
Sandy is
Sandeep
my
Master.
undergraduate batchmate.
Yes, I
Sandy
met
has
Dr.
been
Sandeep.
trained, yeah, in Gangaram.
Dr. Nandi. So, Dr. Olyanka, looking forward to you also contributing this. You recently come from India. You are operating in a city in Nigeria,
Yeah.
challenging
In fact,
environment.
right now we have so many HCC lined up in my unit. We do almost a weekly liver resection now in my unit, and you know, we as we do day by day, we get to see complex cases. Unfortunately, we are in a non-transplant setting, so attending to HCC is more complicated in our scenario. Sometimes we have a very huge tumors, 10 centimeters. Sometimes we have multiple tumors. So it's actually technically difficult in a non-transplant setting. But what we still do is, because we know that surgery is the only hope of these patients, so for 10 cm, once the inflow and outflow is fine, we still try and go ahead and do our hepatectomy. Luckily, like 2 weeks ago, we had a patient that had a very huge tumor, like 12 cm. But luckily for us, the left lobe has hepatophyte. So it really helped us to be able to do a standard resection. Then
Right.
just last week, there's another HCC that I operated. There's the HCC on the second segment 2 and 3, and there are about two other nodules on the right. Luckily, they were
Right.
superficially located. So what I did was I did a left lateral sectionectomy, and I do the non-anatomic resection of the two
Non-anatomic
nodules on the.
resection.
So
Absolutely.
it's not hard and fast. If you have a transplant, in a transplant setting, it's much easier. You can straight away transplant. But in our setting where we are working towards transplant, hopefully by next year, we still try to look at the best we can give to them, because in hepatobiliary, the surgery is still the hope of the patient,
Absolutely.
and that's
Absolutely.
one of the reasons why I came to India for my GI fellowship and hepatobiliary fellowship.
Absolutely. You hit the nail
Thank you.
on the head. Surgery is the only chance of cure in hepatobiliary cancers. I mean, I'm sure the intervention radiologist, so even so what you've just alluded to is a superficially placed tumor on the contralateral side or the future liver remnant. Sometimes for deep
Yeah.
tumors, you can maybe do an intraoperative microwave also. I mean, that may give you a good chance without having to remove or being able to preserve a majority of the
Yeah.
parenchyma by using a
Yeah.
microwave also. But
Yeah.
again, you need a good intervention radiologist for that.
Yeah, again, in Nigeria, we also have that challenge, getting to mobilize the interventional radiologist, availability of microwaves, and other issues. So that is why we just sit down at MDT, just like you said. We look at what can we do, what is the best we can get for this patient
Best.
in our setting.
Absolutely.
So
Absolutely.
just like the last case I told you, okay, fine, though, these are superficially located on the right. Okay, did my left lateral sectionectomy, get the 2 other tumors and get them out. And I think patient has been discharged and is doing fine. So as we
You're doing a
advance our
great job,
care with
Dr. Udayan.
interventional radiology and liver transplant, then we cannot begin to reclassify our patients and say, okay, multiple tumors, go for straight transplant. And for those who can have just normal resection, then we just now go ahead and resect. It's nice meeting you,
Excellent.
Dr. Ashish.
Same here, and you're doing a great job. I can understand the constraints that you face, but I think that you are, all the patients that you can help, you are doing the best.
Thank you very much. Nice meeting you.
Same here. Please take care.
So I think we are okay. So it's from Dr. Ferreira. Okay, we have a few follow-up questions from Dr. Onana. What does it take to have a transplant capacity center?
Oh, that's an excellent question. So,
Very big question.
yes. So first, I would say is the intent. I mean, see, I can understand. See, India is not a developed country. Uh, Transplant, even now in India also, is primarily only offered. Yes, there are a few centers in the government setup which are doing transplants, but probably you can count them on your fingers or one hand, fingers of one hand. Uh, the push has primarily come from the private sector. Uh, Again, you cannot blame the people in power for not thinking about transplant as their priority, because probably there are other more pressing issues that they need to treat, may require lesser infrastructure and cost there, and you need to first manage those things and these come later. Now, problem with transplant is that the infrastructural requirement, the cost implications, the you know uh, paraphernalia, even as we were just discussing, even about major hepatobiliary cancers, you need a very good intervention radiologist. You need good CT and MRIs, doing phasic scans. You need uh, apheresis machine if you're planning for ABO incompatible transplants. You need a lot of infrastructure. So unless, so this is probably we can, what we can do is have a session simply on how to set up a liver transplant program in resource constrained areas. That's a very big question. I would not be able to do justice with it, but yes, I think intent is the first thing. uh, Second would be having mentorship. uh, you need to have people who are already trained in transplant help you up in the first few cases. The skill set transfer needs to happen. um, Problem is that what we saw was that this was primarily a surgeon driven program. So the other branches, radiology, anesthesia, critical care, hepatology, sometimes those become the constraints. You need to have everybody equally dedicated to try and offer this facility to the patient. And obviously management needs to be completely behind the team, because it takes time, it takes effort, much more than our basic GI surgeries or hepatobiliary surgeries.
And Dr. Ashish, one more important thing. So, as a pioneer, be prepared for failures. So, like Sandeep was narrating me the how the genesis of liver transplant capabilities in India, and first seven patients they didn't survive.
Yes.
But Dr.
Yeah.
Nandi, the management had a belief and they bagged. And now in
Yeah.
India, you have achieved such a high success rate in transplants. So that is,
See, Varun, so one thing that I would say is that those were different times. We're talking about the 90s, probably early 2000s. Today, I would say mortality is an event in liver transplant. When we see a patient, we do not think that this patient should die. If there is a mortality, which happens, I mean, still I would say that across the board, if we do 100 transplants, 5 or 7 would have mortality, but uh, uh, majority will go home walking. So today, if I am setting up a program, I cannot say that mortality is common. That is where I am saying getting associated with people who are already trained in transplant to offer that skill set transfer slowly without the patient actually suffering is extremely important.
Okay. Thanks for clarifying. So I think I should readjust my my comment as maybe not for mortality, but still any new initiative
Yes.
requires backing, like a long-term vision.
So 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 Prof Rela used to say it is not the Wild West anymore.
Okay. That's nice to hear. So I think we should talk to
So one
hospital
more
to
question.
help
I think
out.
there's one more question. So
There's
I'm
a
sorry, I'll
patient
just take.
case, Dr. Farah. Dr.
Yeah.
Farah, he wants to discuss a patient
So
case. Dr. Olyanka has
60-year-old female patient presented with right upper quadrant pain for 3 months. Investigation showed a hydatid cyst, but CT says liver pericytoma. So I go for 2 months, but the site doesn't improve significantly. What will Uh, see, what I would like is Dr. Ferra, if you could share the scan images, not the films. If the CD of the scan, if you can upload that on a Google Drive, what I'll do is I can see the scan and then maybe we can have a personalized discussion regarding this one patient as to what the best case scenario with respect to first the diagnosis and treatment going forward. The one thing that I can say is that if it's a 3.5 or a 3 centimeter tumor, and if it is a resectable tumor, I would say that you can probably go in and do a resection upfront and wait for the biopsy later. You don't need to make the diagnosis upfront. Go ahead, resect the tumor, or take it as a tumor. If it is a resectable tumor, resect it with a margin, because it's a small tumor. Liver parenchyma or liver functional derangement should not be an issue. You remove it, send it for histopathology, you will get your answer. But if you can share the CT, I would be happy to see it and then discuss again as to what the best treatment. If there's any other treatment protocol which would be better than upfront resection.
Dr. Siablo has shared that the Africa Hepatopancreatobiliary Cancer Consortium Conference will be in Abuja later this year for those interested in attending. Hey, Dr. Siablo, thanks for sharing. Because logistically being in different continent, it may not be, but if you can help us provide some slot, we can have a speaker like Dr. Ashish or
So we are the host. We are hosting the conference this year in
Oh,
Nigeria, Abuja.
excellent.
So we are willing to have you in Abuja. Hopefully, we'll meet Dr. Sablo.
so. Dr.
Oh,
Sablo,
excellent.
Dr. Olyanka, I request you have attended Jivo Masterclass, you have been associating. Please give us a slot so that we can present a panel of liver doctors, gastrosurgeons like Dr. Ashish and others from different hospitals. So please help in coordinating that. As Jivo, we would like to participate, but in some, if I mean, depending on the event, if there is an online conference, like a few panel of surgeons from here. Okay. So if we have no further questions, I think we can conclude the session. Dr. Ashish?
Sure. Thank you so much, everybody. I mean, it was an honor to have presented this. I hope we have ended this session a little more enriched with respect to primary liver cancers. I know Dr. Olayanka would second this, that this is not everything regarding liver cancer. There's much more. As you keep going inside, there's more and more and more. But at least this is a primer based on which all of us can build our knowledge and help the patients who need specialized care in these tumors. Thank you.
Thank you, Dr. Ashish, and thanks everybody all our colleagues from different countries in Africa who joined today took their time out on a Sunday, and hoping that we can. And it was so good to have some gastrosurgeons from the other side also this time, because when I presented the brief to Dr. Ashish, I told him that to expect mostly general practitioners and a few surgeons, and I said, okay, I doubt if any gastrosurgeons would be joining, but it was so heartening to have Dr. Sablo and Dr. Valyanka here. Thanks a lot. Perhaps we can plan a session in few weeks' time again with Dr. Ashish and doctors like Dr. Valyanka and Dr. Sablo joining. Thanks a lot. Thanks a lot, everyone.
Thank you, everybody. Thank you so much.
Thank you.